that's working with the providers down in Southwest Washington to, well, let's see, what does the screen say? Preparing for the brave new world. So what we're going to do is have some fun together today and go through the material that I've put together. So I'll say a little bit more about what we're going to do today, what we're going to do after today, and jump right in. There's several points where we're going to be stopping and talking. So here's a little bit about our technical assistance process. We're going to start the TA with a couple of topics that we've identified as high priority. For each of the early topics, we'll present important materials generally via webinar. And at the end of the presentation, we'll describe a homework assignment that you as a group can agree to take on now, put off until a later date, or say that's a totally stupid idea and veto it. So this is your process, and we want to be very respectful of meeting your needs. If you take it on now, the group we're going to ask the group to self-organize to complete the homework. And we're expecting that this will evolve into a more planned work plan to help the provider community prepare for what some would describe as an exciting near future. When I say we, I'm referring to myself, Dale Jarvis. I'm a consultant in CPA who's done a lot of work in, I'm a consultant in Seattle who's done a lot of work with the RSNs and with lots of other folks in Washington State, Oregon, California, and other parts of the country. I'm joined by colleagues Karen Linkins and Jennifer Brya, who are actually based in Phoenix, and I'm working with on several projects, mostly in California. And when you get to meet them, I think you'll probably understand why I've brought them into the project. They have a lot of great skills to bring to the table, but we'll talk about them more probably in the next presentation, in the next webinar. What I wanted to do today was start with this concept of living in a post-RSN, post-BHO world, because that's sort of the trajectory that Southwest Washington is on. And so this is webinar number 1. I've brought a bunch of material. I'm hoping to have a rich and exciting kickoff conversation with you about this material. So your job during today's webinar is pretty straightforward. Approach this and future meetings as if the future of your organization depends on it, because it might. And what I mean by that is that there's lots of really exciting things happening around in the whole healthcare ecosystem, and the folks that are really out in front and getting ready for those changes are the ones that I think are going to really not only survive but thrive in this new system. And I want to say that I'm completely convinced that the near future is not going to look like the present or the past. And I'll be talking more about that some today and more next week. What I'd like you to do during the webinar is jot down notes while I'm presenting information, including questions and comments that you want to make. And I'm going to stop at some pre-designated points to officially field questions and comments. And so I'm asking you to be ready to engage. But also feel free to jump in sooner with a question or comment, because there's a lot of information that I've brought today, and I want to make sure that that we don't miss over something, we don't gloss over something that I didn't explain clearly, or you have something relevant to talk about. And I apologize for just getting slides out to you yesterday. In the future, we're going to get materials to you in advance. Take a few minutes to review the material before the meeting. Again, this is really for you, and we want to make sure that we're meeting your needs. And if at any point we're not meeting your needs, please speak up. Okay, with that said, let's forge on. So it's the law. Beginning in 2016, counties and early adopter regional service areas will adopt the purchasing model in which care is delivered through managed care organizations, MCOs, that are at risk for physical and behavioral health services, and where financing is leveraged to support the integrated delivery of whole person care. Counties in these RSAs, which is the acronym for regional service areas, will share 10% of resulting state savings. And so the other sort of piece to add on to the sentence is in 2020, the whole state will move into this model, and so that financing will be integrated in the same way that the state is expecting care to be integrated. And Southwest Washington is one of the regions that is where the wheels are turning. It's moving forward to become an early adopter that will fit with this definition. I want to talk a little bit about the timeline. Not a lot, but if you see the red circles where it says October through, let's see, early adopter regions is the top slice. The middle slice is common elements, and the bottom slice is behavioral health organizations, accountable health regions. And up in the top of the screen, what we see is that in the October through December period, there's this thing called regional data being worked on and purchasing feedback. And what that purchasing feedback is relates to what should go into the contract, the RFP, that will be coming out probably in April for these fully integrated plans, MCOs. And that later in the spring, vendors will be selected and contracts will be developed, et cetera. And so for me, I'm looking at October through December of 2014. Oh my gosh, that's right now. We're actually halfway through the October through December period where the state is wanting to solicit feedback on what should go into the RFP that goes out for the early adopters. So that's a really big deal because the state is basically going to be drafting a new RFP process to hire, if you will, health plans to provide, to get the fully integrated funding per that last slide for the early adopter regions. Oops. And because of that, I've created an agenda for today that's very relevant to that purchasing feedback process. And particularly, so what I want to talk about today is it's all about integrated funding. That's what today's webinar is about. I want to talk about the promise of integrated funding. I want to talk about protecting the community, including the delivery system, against unintended consequences when you move to integrated funding. And then I want to talk about what's next on the technical assistance agenda. So it's a very focused meeting related to, almost the entire time will be related to this whole process of integrated purchasing and the things that I've been learning from the projects that I've been working on around the country. Now there's a very important resource that I emailed out to everyone. If you haven't gotten a copy of this, please email me at dale@djconsult.net. I'm going to have my email address up again in just a couple minutes. A few years ago, the National Council for Behavioral Health put out a paper that relates to states that are moving from a carve-out to a carve-in. And it's full of relevant ideas for behavioral health providers in an early adopter region. And so when we talk about the homework that I'm going to recommend that we work on today, we're going to be coming back to this paper. There's a bunch of ideas from this paper that I've embedded in the slides today. So we'll be talking about that when we get to those particular slides. But let me just go back and look at the title, Ensuring Access to Behavioral Health Through Integrated Managed Care Options and Requirements. So translate that. A state or region moves from a carve-out to a carve-in where the funding is integrated. This paper is about ensuring access to behavioral health care once that happens. So in the spirit of that conversation, I want to start with the promise of integrated funding, and then I want to stop and see what kind of conversation we have. One of the things that I've been very clear about is there's a bunch of places around the country that are organizing to leverage the benefits of health reform in terms of coverage expansion and new funding that connects very much with this theory of change or logic model. And it's almost so simple that I feel a little embarrassed showing you, but it's so important that I feel compelled to make sure that we're all on the same page. And so there's 6 boxes, and the first box basically says, okay, so what we have now is the as-is state. And that as-is state many would describe as a sick care system, because money is flowing only in large quantities only after you get sick. And so there's huge amounts of money flowing to hospitals and institutions. I'll talk about that more in a minute. And what we're trying to do is move from a sick care system to a true health system. And how do you go about doing that is what the theory of change is. The first step is to find seed funding to fund transformation initiatives. And what are those transformation initiatives? They're to support the deployment of what I'm calling high-impact primary, secondary, and tertiary prevention and patient engagement and health literacy initiatives. So that one phrase covers a lot of territory. But the point is that where we need to start is high impact. And when I say high impact, what we're really trying to do is identify folks that are costing the system a lot of money, that if we did something different to support them, they would not end up in the emergency room or the hospital or any of a number of other places nearly as often as they do now. Let's see, I think we have someone that has joined us who may have clicked on telephone. I'm sorry, they may have called in on their telephone, but they have their mic and speakers button clicked. It sounds like they may have fixed it. So they identify, basically do hotspotting, identifying the high needs folks. And what folks are doing is to wrap care around those folks. I know that you're working on some projects down in Southwest Washington. And what happens when you do that, some people describe the result is starving the beast, which is interrupting the supply to the sick care system. I know that's a little pejorative, but it's to make the point that we really need to lower the number of people going into the emergency room and going unnecessarily into the hospital because it's basically sucking all the money out of the community. And we don't do that by cutting rates to the institutional providers. We don't do that by putting roadblocks into all these authorization barriers to prevent people from getting into these levels of care. What we do is we actually wrap care around folks, and I know that a lot of you are working on these projects. So again, I feel like it's a little, I feel a little embarrassed describing this as part of the logic model, but it's really important to know that these 6 steps are really critical, because what we do is when we are able to keep people out of the hospital, out of the emergency room, we free up funding, and the early adopter model is wired such so that we can push that additional funding back into the community further upstream and right-size the system. And when I say right size the system, what I'm talking about is spending more money on behavioral health and primary care and prevention and early intervention so that we achieve at the 2B state, which is a health system equilibrium where we have healthier individuals and healthier communities that are whose lives are working a lot better for them. And oh, by the way, it's not costing the system as much money. We're not spending as much money on sick care, and we're transforming that money into things that really help folks. So I know that this is the mental model in many of your brains, but I just want to make sure that we keep grounded in the fact that what we have to do is create this virtuous cycle of identifying the most expensive folks, wrapping care around them, freeing up that money, and reinvesting that money into the community. Some of you have seen the slide before because I use it on almost every presentation. We'll know we've arrived when we flip the resource allocation triangle so that the triangle as it looks now is upside down, where we're spending so much disproportionate amount of money on all things inpatient and institutional. Not only hospitals, but nursing homes, jails, prisons, other highly restricted environments, and it's preventing us from adequately funding prevention, primary care, behavioral health to keep people out of those all things inpatient and institutional. So the goal is to flip the resource allocation triangle. The goal is to push more money upstream so that we can have decreased demand in the specialty and acute care systems, leading to increased funding for effective prevention, primary care, and behavioral health. So I've just repeated myself like 12 times in the last 2 slides because this is such an important, we can't, everything we need to do as we're trying to move into the future needs to keep this in mind. So if it doesn't matter what kind of services you provide in your organization, you need to be thinking about, are you involved in helping support flipping the resource allocation triangle or not? So how does integrated funding support this? Well, there's a whole bunch of ways, but I wanted to talk about 5. First, as it says on the screen, accelerating the integration of behavioral health services into primary care setting paid from a single pool of funds. So what we're doing is the expectation is going to be basically that every primary care clinic in the country has high-performing behavioral health services that provide mental health and substance use and co-occurring disorder services to folks generally with mild and moderate behavioral health disorders. And integrated funding is helping do that. Secondly, accelerating the integration of primary care into behavioral health settings, again, paid for from a single pool of funding. So this is the other side. These are the 2 sides of bidirectional integrated care. Third is moving toward standardized payment models, contracting terms, and performance measures across all service delivery settings. So what we know is that we have completely different rules for mental health, from chemical dependency, from health care in the state of Washington and the Medicaid system, completely different WACs. This has been the case in Oregon. Oregon's been systematically dismantling these different sets of rules and really trying to create one single set of rules so that we don't have an unstandardized set of rules depending on where the setting is. And fourth, moving towards integrated information systems that support the creation of a single shared care plan, as you can see on the screen, that's available to all members of the care team, regardless of where they work, as well as improve clinical decision support. And finally, focusing on clinical initiatives that wrap care around the whole person in order to save money, primarily on the medical side related to emergency room use and patient admissions and diagnostic imaging. And so what's happening around the country in the places where they're succeeding in integrated funding is they are actually focusing like a laser beam on people with behavioral health disorders, because it turns out that those folks are the most expensive folks in the communities, and they're actually wrapping care around them, doing integrated care, whole person care, and saving money. I'm going to stop right now and see if anyone has any questions or comments about anything that I've talked about so far before I go on to the next slide. Just because I want to touch base with you and see what thoughts you might have. So I'm gonna just go into a cone of silence for 30 seconds and wait to see if anyone says anything.
So Dale, this is Melanie. Last April, I went to a forum over in Portland. It was all of the police chiefs, the EMT directors or whatever, and it was this huge group of people that were talking, and the people from the hospitals, they were all talking about best ways to work with these high-impact people. And I'm wondering if you're familiar with that sort of work that's going on around the country as well. Yeah.
So I'm working with HealthShare, which actually got a federal grant, innovation grant, to work on this kind of project. And I've been working with and talking with a lot of folks that are doing this in Oregon and California, as well as lots of other states. And it's like totally amazing, because people are actually saving money.
One of the fellows was from Virginia, I believe. He had successfully transformed the EMT service over there to save, hundreds of thousands of dollars, if not more. But, it was an amazing system that they had put into place. And I just think that that's really valid and important information.
Yeah, and so one of the projects that people are doing around in the various parts of the country related to what you just said is they're bringing the EMT folks or the EMS folks into the delivery as an official part of the delivery system, and they're basically bringing them in as part of the care team, and they're pushing some health plan dollars to those folks to do care management. So if you ask yourself the question of who in the community knows the people that are ending up in the emergency room best, guess what? It's the people that are in the ambulances that are transporting them to the hospital. And they actually, there's these really exciting projects going on around the country where they're expanding their role to do care coordination. And so the first thing they do when they go to someone's house where the ambulance has been called, where they've been there 20 times in the last 4 months, is have a conversation with them about what they need and whether what they need is best going to be met by going to the emergency room or some other way. And there's really great success stories that are coming out of that, and I think that's what Melanie's referring to about the person from Virginia.
Right.
So we're going to be talking about the cool things that you're already doing and that you can be doing over the next couple of years to really demonstrate your value, because again, that's really critical to fixing the healthcare system. What I'm going to do now is I'm going to focus back on the promise of integrated funding, and I want to take a little road trip. I'm going to take us all on a little road trip to Southern California, where this is already happening. And it's in San Bernardino and Riverside County, and I think San Bernardino might be the largest county square mile-wise in the United States, and I think you can fit like a couple states, small states, into San Bernardino County. It's so big geographically. So I was just in New Orleans at the American Public Health Association conference and doing a presentation with a guy named Peter Curry, who's a psychologist, and he's the director of behavioral health at Inland Empire Health Plan, and we've been working together for a few years now on the project of integrating care and integrating funding. And so I wanted to tell you Peter's story because it's really pretty, well, I find it pretty inspiring, pretty awesome, and very relevant to what you all are hopefully moving towards. So the Inland Empire Health Plan, the acronym is IEHP. You'll see that on the next slides. It's a nonprofit health plan serving low-income families and individuals in two of the largest counties in the country. And so as I'm talking about these slides, picture your community, your regional service area as having health plans that look like this. Because this is, I think, how we together help fix the healthcare system. So they started working on integrated behavioral health at the health plan level in a really big way. And they did that because they saw that physical health and behavioral health were separate and disconnected, that outpatient mental health services were underutilized, and as Peter said here, substance abuse treatment was nil. It was virtually non-existent. And IHP had no influence over the behavioral health network because it was carved out. And the coordination of care, the PCPs, the primary care providers, described trying to refer their patients into the specialty behavioral health system was a black hole because they would make a referral and nothing ever happened. And the other thing was that in this case, the behavioral health services had been carved out to a managed care company, and they were only spending 50 cents on the dollar on services, and the rest was going to administration and profit. So they were just like scratching their heads going, there's something like terribly wrong with this picture. And so what they did was developed a plan to do really cool integration at the funding level, at the insurance company level. And so the first thing they did was they said, we're going to bring the behavioral health program in the funding in-house, just like what we're talking about with the early adopter communities. We're going to streamline the coordination of physical and mental health benefits so that there's not all these different hoops and different buckets and different silos. And we're going to take that 50% admin and profit that was going to the carve-out, and we're going to use that to fund expanded behavioral health services. So Inland Empire Health Plan is a nonprofit organization. They have a 5% administrative overhead, 5%, and they're basically going to take 45 of the 50% that have been spent on service, on admin and profit, and redirect that towards services. So those were key parts of their plan, as well as, of course, directly contracting with the behavioral health network as opposed to having an intermediary. And the other thing that I'm going to dig into a lot is this phrase, eliminate reliance on vendors, manage behavioral health organizations for all behavioral health expertise. And this is a really, really big deal, and I'll be saying more about what I mean, what both me and Peter means by behavioral health expertise reliance from outside. So they had a plan. They started doing their prep work. By infusing behavioral health competency into all of their departments. So they brought people, they hired people who had worked in the behavioral health system in every department at the health plan, including in-house clinical expertise, clinical director, consulting psychiatrist, and behavioral health care managers who are licensed clinical social workers. So again, I'm talking about not just hiring administrative staff, but people with clinical experiences. So these folks became part of the staff of IEHP. And they directly contracted with Behavioral Network to ensure access, which I'm repeating. they leverage web-based technology. And that included an online electronic health record available to all behavioral health providers that had all the claims data that was in their system was made available to the behavioral health providers. All the medical services people got, the diagnoses, the medications. And they also required a behavioral health assessment and treatment plan that be developed upfront, instantly and securely sent to the care manager and the primary care provider. So they leveraged their web-based technology to ensure that the information was made available with the proper releases of information to everybody on the care team, including the care manager at the health plan and the primary care provider. So when you have integrated funding that covers behavioral health and physical health, this just becomes a very straightforward thing to do. So they launched in February 1 of 2010 with a single call center for everybody. They used a no gatekeeper model. So they eliminated pre-authorization, and they basically said, we need to make it easier for people to get into behavioral health care rather than harder for people to get into behavioral health care. One phone number access for both physical and mental health care. And they gave a higher rate of pay for the initial assessment because they want to incentivize prompt access. And the payment triggered by the coordination of care report web form eliminated the black hole. So what happened was it made it, when people got referred, there were providers who were going to get a fairly substantial chunk of change to do that initial visit and the assessment, and they actually increased the access quite dramatically. They reduced no-show rates even without co-location by creating this incentive. They also added new behavioral services. I'm going to talk more about that in just a minute, and then they directly partnered with the 2 county mental health departments, which in Riverside and San Bernardino provide a lot of healthcare services. A lot of behavioral health services. So they planned, they prepared, they launched, and they got results. They increased access to behavioral services by 150%. So what I mean by that is, if 100 people had gotten served earlier, there were now 250 people that got served. If 1,000 people had gotten served, there were 2,500 people that got served. And it was cost neutral to the plan because they reprogrammed that money that was going into extra admin and profit into direct services. It was also that, but they also saved money on healthcare costs for these folks. They dramatically improved the coordination of physical and behavioral health care. They achieved medical cost offsets for their high-risk, high-cost population. So they actually kept folks, they started flipping the resource allocation triangle. And they also began infusing behavioral health expertise within the health plan to respond to crisis calls. Because remember, there wasn't like a mental health crisis call line. There was a 1-800 call line that anybody called for anything. And by infusing behavioral health expertise into the call center, they were able to do a lot more effective responding to a much broader range of calls where there really was a behavioral health component involved that may not have been the reason why the person thought they were calling in the first place. And they also did really well on their National Committee for Quality Assurance accreditation requirements for behavioral health in their 2012 audit, which was one thing they were worried about. The worry they had is, if we bring this in-house and we start doing it for the first time by ourselves, will we bomb out on our audit, on our NCQA audit? And it turned out that they didn't. They did great. And they developed this network, a very broad provider network. It's really important to know that they were paying the behavioral health providers and FQHCs. They were paying behavioral health providers. MHP stands for the Mental Health Plan or Program. MHP is basically County Mental Health Services, and CBOs are community-based organizations. So those are the nonprofit provider, behavioral health provider organizations. And they also had a whole network of individual therapists who were in private practice. So you have to remember, they're serving the whole Medicaid population in these two counties, and they're meeting their needs at parity, and they're providing services and paying money for people with mild, moderate, serious, and severe disorders. So there's no like access to care standards where if you have a mild and moderate disorder, you get paid for out of the health plan funds, and if you have a more serious and severe disorder, you get paid for out of the behavioral health funds, and we fight about it. I mean, it was integrated funding without any sort of fighting over whose person this is, who's responsible for whom. There's one other part of the story, and then I want to summarize the lessons learned, and I want to see if you have any questions or comments before I shift gears and talk about the potential unintended consequences of this. So let's keep going. So they described their behavioral health integration as a platform for population health care. And what they're really talking about is more than, it's really addressing the whole person care. And they did 3 really cool initiatives as part of this work in addition to everything else they were doing. They adopted a county-proven wraparound program for dual-eligible folks that had a serious mental illness with a goal of getting a big return on investment. And I'm going to dig into that one in just a minute. But what they did was they funded a really cool wraparound program. They started an autism assessment center of excellence because they anticipated that was going to become part of their benefit pack that they were going to be required to provide, because there was all this fighting about who should pay for autism in California. And then they combined pain management, mental health, and substance use intensive outpatient program to create a new narcotic misuse center of excellence. So these are 3 of very powerful, very important, actually nationally recognized initiatives related to behavioral health that they pushed out as they became more competent in understanding about what's needed to achieve the triple aim for their patients. So I want to dig into this first one about the wraparound program. So they started this program where they hired Telecare. Anybody ever hear of that organization? I'm just joking because I know that Telecare's in the room. Somebody from Telecare's in the room. And what they did was they did a wraparound program for folks that had a serious mental illness who had been in the hospital, who had been high utilizers of inpatient care, and they paid them a case rate to basically wrap care around them. And you can see that they dramatically reduced the psychiatric inpatient admissions 61% over a 6-month period from 36 to 14. They also reduced emergency room visits and brought down emergency room costs by 74%. So you can see the numbers on the screen, how many emergency room visits from 89 to 29. The average cost was 87 cents per member per month before, and it dropped down to 23 cents per member per month afterwards. So this is so the CFO at the health plan basically, stood up and took notice about this intervention. Basically what we're seeing here is the health plan taking leadership, pushing money into new money into the community on top of the money that was already being spent for new initiatives to save money on the healthcare side, to create that virtuous cycle. That's the theory of change that I was talking about earlier. And the total cost per member per month went, so this is medical and behavioral health, went from $4,131 per month to $3,084 per month. So how would we describe this one project? We have health plans that get it in terms of the importance of integrated behavioral health treatment. We have those health plans working with behavioral health providers that get it in terms of focusing on the whole health of their clients. We have health plans and behavioral health folks working with medical care providers that also get it in terms of focusing on the whole health of their clients. And when you get those three groups working together, they're able to rock in terms of actually having one organization funding them without the kind of barriers that we've seen historically in other settings. And save a lot of money, but even more importantly, improve the quality of life of folks who with behavioral health disorders, where the health plan, this enlightened health plan, I think is safe to call it, was the catalyst for change because they had really great leadership and they also had the money they had their hands on the money. I'm going to stop before I move on to the next section about unintended consequences, which is a really important piece of the puzzle, and see if anyone has any questions or comments at this point.
I've got a question, Dale. This is Richard Drandoff from ChangePoint. And
Yep.
I'm wondering if you have any information about what happened in the integrated health plans with who was selected or who was eligible to treat these individuals for tobacco addiction. One of the things that we know in behavioral health is that probably 80 to 90% of our clients in mental health and in addictions are tobacco users, which, in my way of thinking, leads to a lot of the high utilization that we've got in that population. And it strikes me that behavioral health providers are in a unique position, especially CD providers, to treat their clientele for tobacco addiction. And we do it. We have done it forever. We just don't get paid for it. And I want to know if you have any experience in that realm and whether or not the Inland Empire success model included having CD providers treat people for tobacco addiction.
Oh, that's a great question. Well, it's not a great question, but it's a great point, especially the part about the connection between tobacco addiction and really expensive health conditions and people's bodies falling apart. I don't know the answer to the question, but as soon as I get off the phone, I'll write Peter, and Peter Curry, who's the head of behavioral health there, and I'll ask him, and I'm sure that he'll get back to me right before our webinar next week, and I'll let you all know the answer to that question. I know that that there's been really stupid things going on around the country, around CMS doing things like saying you can't pay for tobacco cessation programs, and people are really pushing back on that. And so I'm actually really curious to see whether they've focused on this and what they've done. I don't know the answer, but I'll find out.
Yeah, well, most of the money in our region goes to the Quid Line, which is now owned by people that make vapor cigarettes, and there's an enormous amount of profit in it and very few positive outcomes. And for whatever reason, this company that controls the Quid Line nationally has managed to get into the state legislatures as well as the departments of human services and get themselves named as the sole provider, and they're not having any success.
Oh, interesting. I'll find out from Peter and get back to you.
Dale, about the call center?
Yeah.
Okay, thanks.
About the call center, who actually mans the call center as far as what level of credentials do they have, and is that part of the healthcare plan? Is it the plan that has the call center, or?
Yes. Yes, so the plan has, in this case, the plan has the call center. And I can't remember, I used to know, but I can't remember, but I'll find out, whether they have a warm line, because I thought they did, and who staffs the sort of a hotline, and if there's a warm line, who staffs that? I can't remember, but I'll find out.
Because they'd have to have some kind of medical background or mental health,
yeah.
or they're going to have some kind of background there to be able to work with people into the different.
Oh yeah, no, there's nurse.
I
know I was there. I had a tour of their operation. They have nurses, and they have licensed clinical social workers that are staffing the call line, but I can't remember who else they have that's doing that. And Peter's talked about this a lot, but I just don't remember off the top of my head.
Because I think that's the essence of the whole thing, is having that good call center that's able to work with the folks as they call in.
That's right. That's
Isn't
right.
it?
No, oh yeah, and what's really important to note about this is if you're going to be NCQA, so NCQA, National Committee for Quality Assurance, is the organization that accredits health plans. And in many states, you have to be accredited by NCQA to get a managed care, a Medicaid contract. It's not the case in behavioral health. And the standards for call centers are really quite high, the NCQA standards. So it is a really big deal. It's like, and your point is well taken, and I can tell you that they have done a really, they've passed their NCQA accreditation on this, and they do a really good job with their call center. But I'll get some more details and share it with you.
Thank you.
Okay, I'm going to keep on. I want to talk about the unintended consequences, and then talk about our homework assignment, and then we'll be finish up for the day. So I'm thinking about the Inland Empire Health Plans bill, and unfortunately, what I have to tell you is that they're an exception to the rule. That most health plans don't fully understand the importance of addressing the whole health needs of their members with behavioral health disorders, don't have the experience or onboard competency with behavioral health disorders that exist at an Inland Empire Health Plan, and aren't willing to risk precious premium dollars to invest in the kind of triple aim pilots the IEHP has done. And so, that's the bad news. Before the current round of health reform, 2 states, Tennessee and New Mexico, tried a full carve-in of the mental health services. Tennessee was forced to change back to a carve-out after numerous providers experienced extreme financial distress, creating severe access problems for consumers. And New Mexico was denied its initial waiver renewal by CMS in 2000, in part because only 55% of the behavioral health premium was going to services. Sounds familiar to what Peter was talking about? Since that time, New Mexico has moved back to a comprehensive carve-out, pooling funds from several state departments. So we've had some really bad experiences. And for me, the key questions are, have we learned the right lessons from the Tennessee and New Mexico carve-in experiences? And what are those lessons? Well, I found 17 of them in the National Council paper. I want to do a rapid tour with you because I know that going through 17 items is a little bit brain dead making. But it's important to sort of do a rapid tour and then to talk about what we want to do with trying to make sure that we protect against unintended consequences of a carve-in. So what the paper basically said that this is the National Council paper I was referring to at the beginning, is that AAA plans have the following core competencies and policies. And so think about whether you think these are important for you, your organization, and the folks that your organization serves, and whether you would consider this a low, medium, and high priority because there's a homework assignment related to this list of 17. These plans identify people with youth with serious emotional disturbances, adults with serious mental illnesses, and adolescents and adults with serious substance use disorders. So they actually work on saying, so who are the people that really have complicated behavioral health conditions? They have enhanced outreach and engagement strategies to support access to individuals with these complicated disorders who are reluctant to enter treatment. They understand that having a call-in number, that they need to do more than just have a phone number. That they need to go out they need to have people that go out into the community. They need to pay for people to go out into the community to engage these folks. That's what I really meant to say. They have consumer involvement in policy making and service delivery. They have a focus on building resiliency and recovery. They have awareness and attention to stigma. So one of the things that I want to reinforce is that most health plans wouldn't know what most people who work at most health plans wouldn't even know what I was talking about with these 5 bullets. And the health plan really need to not only understand this, but embed this into the DNA of their organizations. I want to say a few more. So I've gone through 5. They also understand the relationship between adverse childhood experiences, ACEs, other trauma, and behavioral health disorders. They understand the importance of a psychosocial medical approach to health and wellness for individuals with behavioral health disorders as opposed to just a medical model. They provide financial and structural support for multidisciplinary care teams to coordinate the behavioral health, actually I should say the whole health care of complex clients, including behavioral health. And they support a broad range of non-traditional services for at-risk individuals, including peer support programs, community stabilization services, skill building, psychoeducation, smoking cessation, etc. They have long-standing relationships with allied systems, including child welfare, schools, and corrections, where they collectively own the problems with the consumers. They experience braiding and blending of funding with the allied systems noted above. They have authorization policies that reflect the long-term nature of serious mental illness and substance use disorders. They have experience in providing plan-level care management for complex individuals with serious mental illness and to a lesser degree substance use disorders. They prioritize the funding care plans for the most complex individuals with behavioral health disorders. They have dedicated funding for the populations described above. They have a long history of credentialing organizations and supporting the use credentialing organizations and supporting the use of both paraprofessionals and professionals, as opposed to just saying we only allow LCSWs and psychologists and physicians and nurse practitioners to provide services to folks that will pay for. They have a deep awareness of the complexity of psychotropic medications and the need for a broad formulary to address the needs of the enrolled population. So this is a pretty robust list that I just blew through really fast because I wanted to make a point that we need to step back and we need to work together to think about the fact that there's a lot of behavioral health organizations that have developed capacities. There's a lot of behavioral health, managed behavioral health care organizations, at-risk entities, RSN-like entities that have developed these capacities. There's a lot of RSN-like entities that haven't developed these capacities. And there aren't many health plans that have. And what you guys need, guys and gals need in your region, if I can be so bold as to say, is only health plans that get what you think are the most important items on this list, not only get it, but have it built or in the process of building it into their DNA. And you need the support from a state healthcare authority to ensure that you don't have health plans that get fully integrated contracts that have no idea what these 17 things are. So again, I'm going to stop for a few minutes and see if you have any questions or comments about anything I've talked about so far.
How do we know if they have any awareness of these 17 items?
So in the next slide, what I'm going to talk about is organizing a work group to put together some feedback for the state. And what I really want you all to do, and we're willing and interested in helping you, is to carefully, well, let's see, let me jump ahead and look at the next slide and answer your question from that perspective, and I'll take more questions. The sector. I can't read when I see so many things, when it all blaze out at me at once. So I'm proposing that we do a set of next steps to provide feedback on the early adopter health planning procurement process and contracts. And what I'd like to see is for the procurement process to dig into the areas on this list and anything else that you see in the document that you think are important. And for the contracts to have teeth around requiring that health plans do certain things to support the behavioral health, folks with behavioral health disorders. So that's the short version to your question.
Okay.
If there's not a process to separate the wheat from the chaff, and if there's not contracts that have teeth, then there's no guarantee that any health plan will have any of these competencies, and you won't end up in a situation that just doesn't support the folks that you're trying to serve. And so if we look at, so here's my proposal, that between now and next week, you guys go back and think about pulling together a small work group to draft a set of recommendations, and our RTA team will help support this. And so what I'm proposing is that at the beginning of at the session next week, we're going to ask for volunteers for this work group if you guys indeed want to go down this road. And that each work group member, that we create a little mini timeline. So this is basically a December project, where each work group member reviews the list of 17 and carefully reads the National Council papers, looking for key elements I missed. And sort of one of the requirements of the homework that homework assignment is I didn't get everything, so I'm saying you got to find at least one that I missed. So let's just say that there's 6 people that say, yeah, this is like really important, and I know I'm incredibly busy, but I understand that this is like incredibly important. So those 6 people would review the 17, they would read the paper, they would take notes, they would add elements that I missed. so that we're doing a brainstorming. What are all the possible things that ought to be in the procurement process and the contracts? And then we'd come together and we'd review what everybody came up with. And then we would, and let's just say that we went from 17 to 30, we would prioritize. We'd say, okay, so what are low, medium, and high priorities on this list? What do we really think? And we'd do a little process where we coded them and identified which ones we thought were the medium and high. And for those medium and high, we would draft language that translates the content into what might be found in an RFP and also what might be found in a contract. And we would get some technical assistance around that kind of contract language so that we wouldn't have to be making it up ourselves without, pretending to be lawyers when we're not. And then we would bring our list and our language back to the full group for review, feedback, and finalizing. And then we don't know what the exact process is for giving feedback to the state, but at a minimum, we would have our work. I would suggest we would have our work group meet with the state in person and basically say, we've been doing this deep work on this project, and this is our feedback. And I would also suggest that we add a seventh, which is and share this feedback with all the other stakeholders in the state. So I'm just curious. I'm not doing an official vote right now, but do you think that this is what I just described is important enough for you all to organize a work group, a mini sort of ad hoc temporary work group to work on this project over the next 5 weeks, 6 weeks? Any thoughts on that? Somebody said yes.
Yeah, I think that if we don't do it, then it'll just get dictated to us, and the important elements that we know about won't be there. We have had meetings with a number of plants that are planning to submit an RFP, and to my way of thinking, they didn't know a whole lot about behavioral health and how it integrates with physical health, and they didn't seem to care all that much. So I think it's really important that if we don't want to get, put into a corner, backed into a corner, that we need to come out with our own opinion.
We've already experienced some feedback from one of the health plans. They don't like the fact that providers are organizing. And they've been pretty vocal about that. I think, be really transparent. Health plans, they have an idea of how to make money, how to be in business, how to be successful. And as we organize and try and come up with these priorities and everything, they've already voiced that they have some concerns about that. They don't want restrictions. They don't want us telling them how to run the business. And I think when we look at what we've learned and lessons that you've learned and are sharing with us, what we want is to be successful. What we want is to achieve the AAA. And where they're a model where that's been done successfully, I think we need to learn and implement what we can for the state of Washington. Another thing I want to say is that we're an early adopter site. And with that, we're moving ahead of the rest of the state. And I think there should be some concessions that are made for an early adopter site because we're leading and taking a lot of risk. And so I appreciate your consultation and technical assistance to help us identify some of these priorities that will help us to be successful.
Great. So it sounds like I'm rather than taking you off on the wrong track, I'm on the right track with where your brains are at around this.
Yes.
I feel so lucky to. it's not just Inland Empire Health Plan, but there's a group called Rocky Mountain Health Plan on the western slope in Colorado that I could have told the story about, but I didn't have as many great slides from the guy there that I've worked with. But it would have been a similar kind of great story. And there's also some stories from some of the coordinated care organizations in Oregon that are more recent, because remember that they turned the switch on in 2010, so they've been working on this for more than 4 years. But there are a bunch of great places out there, and I feel really lucky to have had the opportunity to work with them. And I think it's really important that we just pull this work group together. So between now and next meeting, I'm going to put together a little process for us to put that work group together and be thinking about if you want to. It's going to be very time limited. We're going to need about 4 to 6 hours of the members' times to help us work on this, and we'll just push this puppy forward.
Hey, Dale, is there any way that we might get Peter to tell us about problems they encountered or barriers that occurred for individuals trying to access those services, or, I mean, problems with the system, so that we might troubleshoot those in advance? Yeah,
great idea. Well, what kind of problems do you have now with people accessing the system? I mean, I know that you could go on for that this is maybe a longer conversation, but if you could just give me a flavor.
To be honest with you, I think that people don't really know how to access mental health services. A lot of the people that I talk to that call me and they're unable to access care, they don't know how to go about doing it.
Yeah. So not knowing how to access is a really big issue.
Yes.
Well, we're going to talk about this next week. I'll show you in just a second when our next webinar is, and when I talk to Peter, I'll ask him that question. When I write him, I'll ask him that question as well. But you know, we did the presentation yesterday, so it's just like totally fresh in my mind. And you know, he basically said that okay, so they increased access by 150%. And what they basically did was so they sort of made everybody who worked, I mean, they created a situation where the people at the who worked at the health plan, who were in the call centers, were much more knowledgeable about behavioral health, and they had a lot more providers who had more open access and were getting paid more money to do the assessments. I mean, there were a few levers that they did, and they had almost nobody getting substance use disorder services, and so they basically built a network with enough capacity and paid them enough and informed the folks enough. But I'll ask them to tell me what other kinds of things we might be able to tease out about why folks were what kind of problems they were still running into. That's a great question.
Well, there's also the stigma part. I mean, if the individual is directed towards primary care or through primary care directed towards mental health, then the stigma may or may not remain. I mean, I don't know, but I think a lot of times people are afraid of having that label attached to them as well.
Of course. Of course. And you know, it's a really big issue, and it's still with us, alive and well, if you will. So we just have a couple more minutes. I want to get us to the finish line. So mark your calendars. Next Tuesday, November 25th, same time, same place, same virtual place. Do we have the same room for next week, or is it a different location for those on site?
Same room.
Okay.
But the projector will be set up a lot quicker.
Super. Same time, same place. The question that we're going to tackle next week is we're going to start with a little more self-organizing around this mini project that I just described, and then we're going to jump into what does the behavioral health provider organization of the near future look like. I have a 2-minute homework assignment for everybody that's on the call with a deadline of this Friday at 5 p.m., yes, the day after tomorrow. And the question is, I'm trying to meet your needs around getting ready for health reform. So based on what you know today, what is the most important technical assistance your organization needs to survive and thrive over the next 3 years as health reform rolls out? E.g., I want to have 2 EGs. What areas of help do you need? E.g., what's keeping you up at night? And what I'd like you to do is for everybody in the room to write down my email address, dale@djconsult, if you don't have it, and to just like take 30 seconds, take 2 minutes, take 5 minutes. I really want to get a list from all of you what's really important to you in terms of getting support, because we have a budget and we have really smart people working on this project who have like amazing experience with this stuff, and we want to do brain dumps with you and give you ideas and help you in whatever ways we can. And we really want this to be an active process with you. So we're starting out with some webinars, but we will be spending time on site with you. We're just sort of waiting until we get a little bit further into the project so that when we come on site we can be as effective as possible. So I'm going to, let's see, if you didn't get an email with the slides, it means that you weren't on the email list because I sent the slides out to folks. Send me an email and say I didn't put me on the list. And what so these slides are a smidge different than what I sent out earlier. I'm going to send out the updated set of slides to you as well. And just the final piece to tell everyone, if you haven't heard me say this before, everything that I do is open source. So I'm going to send you the actual PowerPoint slides as opposed to a PDF, and you can feel